The therapeutic application of monoclonal antibodies started back in the mid-1970s with the discovery of hybridomas and now has developed to being the predominant class of new medicine developed in recent years. Particularly in their application for cancer treatments, there now exist approximately 100 monoclonal antibodies that help aid individuals in the treatment of a range of immunological diseases and cancer therapies. One of these monoclonal antibodies that has been developed is rituximab. Rituximab is used for a range of treatments, some which include chronic lymphocytic leukemia and non-Hodgkin's B-cell lymphoma. Rituximab is categorized as a chimeric monoclonal antibody, as it contains the joining of the antibody variable domain of a selected mouse to that of a human antibody consistent domain. The chimeric structure of rituximab comprises human immunoglobulin 1 and kappa chain constant regions and heavy and light chain variable regions from a murine antibody to CD20. The murine variable regions selectively bind to the CD20 antigen expressed on the surface of both normal B lymphocytics and B-cell lymphomas. The presence of a human constant region allows rituximab to bind to Fc receptors on human effector cells to mediate both complement-dependent cytotoxicity and antibody-dependent cell-mediated cytotoxicity and decrease its immunogenetics. The process begins with a transgenic mouse that has been genetically manipulated such that it now carries a human immunoglobulin gene locus. This allows the mouse to be programmed to make antibodies with a human sequence. The mouse is injected with an antigen that induces an immune response. The B cells produce antibodies that bind to the injected antigen. When the tier of the antibody in the mouse is high enough, they are euthanized and then the spleens are removed for hybridoma production. Hybridoma production involves fusing the isolated B cells with immortal B cell cancer cells to produce hybridomas. This hybridoma has both the antigen-producing ability of the B cell and the high longevity of the meiola. The hybridomas can then be grown in culture, ultimately grown and produce high amounts of specific monoclonal antibodies. Rituximab is designed to help treat chronic lymphocytic leukemia and non-Hodgkin lymphoma. Non-Hodgkin lymphoma is a blood cancer that is generated in the white blood cells. It is also considered a cancer of the lymphatic system. What happens is the growth of the abnormal cells expand to form a tumor in the lymph node that can then spread to the lymphatic system from the lymph vessels or to another organ via bloodstream. Chronic lymphocytic leukemia is also a blood cancer. It starts with the lymphocytes in the bone marrow becoming a leukemia cell that crowds out other cells. In chronic lymphocytic leukemia, the abnormal cells can mature to a degree, however they do not function as proper white blood cells. Rituximab is a targeted therapy drug given in conjunction with chemotherapy to treat the chronic lymphocytic leukemia and non-Hodgkin lymphoma. Why rituximab is given with chemotherapy is because of its mechanism of action, as it targets B-cell marker CD20. By binding to B cells via the CD20 surface marker, the monoclonal antibody can directly initiate the complement-mediated cytotoxicity and antibody-dependent cell-mediated cytotoxicity death of B cells, as well as indirectly cause sensitization of cells to chemotherapy, apoptosis, and structural changes to the binded cells. Why rituximab is used to target the surface marker CD20 is because once a cell has started to develop into a B cell, the presence of CD20 is there as a transmembrane protein. Naturally, this means not only are the malignant B cells destroyed, but the healthy ones as well. So why is rituximab still in use? The conventional treatment for chronic lymphocytic leukemia and non-Hodgkin lymphoma, such as radiation and chemotherapy, both carry risk of toxicity and are non-specific methods that do not target tumor/cancer cells specifically. With rituximab, the depletion of B cells is considered transient, lasting around a 6-month period, with no known signs of increased risk of infections and decrease of immunoglobulin G concentration levels. While the population of pathogenic antibodies are depleted, rituximab does not act on other plasma cells or other protective antibodies, as they lack the presence of CD20. Instead, rituximab interferes with the synthesis of new plasma cells that require CD20 positive B cells as an intermediary, and the function of B cells. For example, the role of antigen-presenting cells to T cells is effective in autoimmune diseases. Another advantage of rituximab is that the selection of CD20 proteins is highly expressed, especially for B-cell lymphomas, and after antibody binding is not downgraded, as well as shed, modulated, and secreted to the circulation, allowing it to be a target for passive immunotherapy. In first-line treatment for patients, a phase 2 trial was conducted to test the efficacy of treatment using a single agent of rituximab. The purpose of the study was to assess the efficacy and toxicity of the first-line single-agent rituximab, followed by retreatment with rituximab at 6-month intervals in previously untreated patients with chronic lymphocytic leukemia or small lymphocytic lymphoma. The study was conducted on 44 previously untreated patients who received 375 milligrams of rituximab weekly for 4 consecutive weeks. If treatment showed promising findings with objective responses, the study continued, and the patients received identical 4-week rituximab courses at 6-month intervals for a total of 4 courses. The response rate to treatment was 58%, with a complete response of 9%. A follow-up was done after 20 months, and it was found that the median progression-free survival timeframe was 18.6 months. After 1 year, it was noted to have a PFS of 62%, and after 2 years, 79%. Overall, nearly all patients tolerated treatment and the study was adequately controlled. 2 patients identified having a grade 75% fusion-related toxicity, but there was no death, infection, or cumulative toxicity episodes. Concluding the experiment, it was seen that treatment against chronic lymphocytic leukemia was successful in having significantly higher response rates and limited severe implications from the treatment plan. Single-agent rituximab used at a standard dose and schedule is active in the first-line treatment of patients, producing substantially higher response rates than previously reported in relapsed or refractory patients. Evidence from this study suggests that the treatment was most successful short-term within 1 to 2 years, while using this treatment longer drops the efficiency to 20 to 25% after approximately 5 years after the first administered treatment. Rituximab is used to treat chronic lymphocytic leukemia and non-Hodgkin lymphoma by targeting the CD20 protein found on B cells that are commonly abnormal in both diseases. It then causes complement-mediated cytotoxicity and/or antibody-dependent cell-mediated cytotoxicity to eliminate any possible malignant B cells.